bit of time out of your schedule. We know everybody is extremely, extremely busy. And the fact that you're willing to give up a little bit of that time to learn about this exciting kind of revolution in foot and ankle surgery is really impressive. So tonight, I'm going to talk a little bit about what are bunions, give you just some basic informational knowledge about it. I'm going to give you a little bit of the history of how you get them, what we did to treat them before, and why Dr. McAleer and I think that without a doubt, without a question, you should pick this way if you decide to have surgical care to get your bunion deformity taken care of. If you would do us a favor, there's probably going to be a lot of questions. Please write them down, take advantage of the pen and paper in front of you. We'll have a session at the end. Feel free to ask whatever you would like about the subject. Dr. McAleer and I have, together some decades worth of experience. And interestingly enough, we met when we went to medical school in Chicago for the first year. So we're going to give you some kind of point-counterpoint information. And we hope that when you leave here, you have the ability not only to tell your family and friends what a bunion deformity is, tell them how you got it, but also the best way to fix that, okay? Now I want to start with a little bit of a history. The most common thing I get from people is, I've heard that is the most painful surgery to ever have, okay? Some of you may have heard this before, and that's perfectly fine. It's okay. What I tell people is, when my wife was pregnant with each of our children, somebody came up to her and said, oh my God, this bad thing's gonna happen, right? But at the end, we have these 3 amazing children, right? So there is a little bit of angst about it, but I tell every patient that I have, it's okay to be nervous. You know why? Nervous means you care about the outcome. And if you care about the outcome, chances are you're gonna do exactly what you need to do to take care of the problem, okay? Let's get started. Go ahead. Just a little bio about myself. I went to residency in Chicago. Mount Sinai Hospital was a level 1 trauma center. There were no orthopedic residents there, so me as a podiatric resident, I did the orthopedic side as well. It meant for a lot of sleepless nights, but it gave me the best training I could possibly ask for, okay? Board certified by the American Board of Foot and Ankle Surgeons, as is Dr. McAleer. We put in a lot of time and effort to keeping up with what we need to do to take care of people the best way. And being board certified is one of those ways. Go ahead, next. So simply, what are bunions? Most people look at it and say, oh, I got this big bump on the side of my big toe joint. What is that? My mom had it, my dad had it, Aunt Susie had it. What is this that I'm really dealing with? So this is the first part of what we're going to talk about. What are bunions themselves? Okay, let's give you a little bit of anatomy. This long bone right here, this bone is called the first metatarsal. And it is the primary factor that we need to consider when we talk about surgical care for fixing bunion deformities. There's 2 bones in your big toe. There's a proximal phalanx and there's a distal phalanx. Each of those help make up the part that you see kind of leaning and pointing to the side, okay? Go ahead, next. So, what are they? How did I get it? A guy that I respected tremendously in my residency told me the easiest way to explain it is a bunion deformity is a progressive subluxation or dislocation of your big toe joint. The big toe starts to drift further and further because we have a couple of metatarsals that start to slide apart, and as they slide apart, our body's natural reaction is to try and balance us out. If you've ever watched somebody walk down the street who has a really bad shoulder or a really bad hip, you kind of see that shoulder or hip just lean into one side, right? But what does their head do? Their head kind of balances back so they can stay straight, right? The foot, the arm, any part of your body does the same thing. One part will always adjust to the other to kind of try and keep you somewhat balanced, okay? The most common reason for bunion deformities, genetics. Somebody had it, they gave it to you, you won the genetic lottery, nobody wanted to, but you did, right? Environmental factors play a role as well. What type of shoes did you wear? What kind of activities did you do? Was there any trauma involved? How hard were you on your feet, right? We all have things that we really, really enjoy doing. And the human body was built for movement. But the truth is that movement has a cost. And sometimes that cost is an orthopedic problem, like bunions. Your overall foot structure. There are so many different bones in the foot, 28 to be exact, that our foot structure can change as we grow up, as we develop. Our foot structure changes over time. It can change for women after they've had a child. There are certain types of foot structures that actually lend themselves to a higher incidence of bunion deformities. Now there's a bunch to that, but basically what it means is if I have a certain foot structure that places more pressure on one joint, what's that joint going to do? It's going to adapt, right? It's going to change. It's going to move. It's going to try and keep you balanced. But the truth is there's a cost to that balance, right? And we're going to dive into that a little deeper. This is really a multiplanar problem, and Dr. Mackler is going to show you some fabulous slides about how we fix this in multiple planes. One of the hardest things for me to learn when I went to medical school was all these different planes and how they rotate and all the things and all these different shapes. But once you really wrap your head around the geometry of it and you understand that it's a three-dimensional problem, the fix has to be three-dimensional. And that's what we're going to talk to you about tonight. Go ahead. How else? Now, personally, this is not a problem for me. These are mine. I took a picture. I was wearing those earlier in clinic. You know, the things that look really, really cute, women, are probably not the best for you functionally. I get a lot of questions about what kind of shoes should I wear? And I tell people the same answer. I've told them the same answer since I got here in 2006. As long as you're comfortable and you can get through your day, wear them. Yeah, some shoes are better than others, but we all have a different level of activity that we have to do. Some people require custom-made shoes, custom-made inserts. I see plenty of people who walk around in flip-flops all day. And they're like, yeah, I'm perfectly fine. Other people couldn't put a pair of those on for anything. Their feet would hurt in 20 minutes. But the truth is you have to have some level of comfort. Now, most of the time, supporting your foot with shoes other than this would be very, very helpful. Next. All right, so how do we fix bunions? Now, exactly, I was waiting. The picture on the left is actually something available for sale on Google. It's $55. You can fix your bunion, I think, overnight, according to the website. You can dial in some rotation. I'm not really sure how you get that thing in your shoes. I'm not even sure how it would be comfortable sleeping with it. But there are a number of people buying apparatuses such as this in hopes that they will fix a structural problem. Now remember, about 2 minutes ago, I told you it's a multiplanar problem. Means that we have to fix it both up and down, side to side, and in a rotational fashion like this. Okay? That brace isn't going to do it. It's just not going to be helpful. And I don't know how many people I get bringing magazines to me and they open it up and they go, is this going to work? And I usually tell them, no, no ma'am, no sir, that's not going to help you. You're welcome to try, but I think you'll be disappointed with the outcome. Okay? The second one, I could not believe. I really saw this on Google as well. A simple type search, how to fix my bunion, and this pops up. Whether it's a joke or not, I'm sure somebody looked at it and said, maybe that would work. It's pulling my toe back straight. I don't know. Okay? I would suggest you avoid any and all of these things and give some significant consideration to what your foot and ankle doctor tells you. Okay? Next. Okay, surgical care, because that's what we're talking about here tonight. We're talking about the best way to fix this problem that affects females 2 to 1 over males, but affects millions of people. Okay, I see this problem every day. Multiple people have it, and they all want to know, how do I make it better? Well, I can tell you, I've sat in medical school, I've sat in residency and had to calculate angle after angle after angle. If there is a bone in the foot, I can tell you that somebody wanted to name an angle after themselves. And they said, well, let's measure this to this and see what comes out with it. And then, of course, your professor goes, well, what does that angle measure? Well, if that angle is high, maybe this does this, and this does this, and after a while I was like, this can't be right. It just can't make any sense. So when I was training at Mount Sinai, there was multiple fractures that would come in all the time. And for every fracture, there's a classification system. Again, somebody wanted to put their name on something, right? So the one attending would say, well, you know, according to the Weber classification, what kind of fracture is this? And to be honest with you, there were so many, I just don't know how you keep track. So the one attending, the one guy who taught me the most that I just adore to this day, said, hey Bill, when you call me, tell me if the bone's broken and needs to be fixed, or if they just need a cast. And then I'll know what you're talking about, right? So we get caught up in a lot of things that maybe don't make a whole lot of difference. Now we still pay good close attention to a few of these angles, but I think you need to understand that if somebody is telling you, well, you know, da 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 da, and you just don't really get it, probably is they're not getting to the real meat and potatoes of the situation, right? What's in a name? Each one of these has a modification. Each one of those names is a way that you can surgically address a bunion deformity. Each one of those has somebody else who came in after them and said, well, let's change it a little bit, and I'm going to stick my name to it. Again, each one of those has an angle. Okay, if you're doing an Austin bunionectomy, well, it needs to be at 60 degrees. You need to check it in this plane and this plane. If you're doing a scarf, or what's called the Z osteotomy, you know, the first cut has to be at this degree, followed by the second cut down the horizontal section, followed by the third cut at this degree. I trained with the guy who invented the scarf osteotomy, and I can tell you he was not even that precise with it. He said, this is the way it looks, this is the way it needs to be done. I don't know what all these other guys are doing, but you don't need to worry about that stuff. The Vogler. Well, 60 degrees wasn't good, so somebody said, let's do it at 40 degrees and see what happens. After a while, guys, you can invent ways to cut a bone and to move it over, but again, if you're not addressing it up and down and side to side in a rotational fashion, you're not going to make it any better. Okay? Next. The first picture on the left is an example of the Austin bunionectomy, a 60-degree cut that translates a part of the bone. It doesn't address the entire deformity, it only addresses a portion of the deformity and moves it over. Employed for a long time, has done good things for people. Some people in this room may have already had that procedure. You may know somebody who had that procedure. And it worked pretty good. Every podiatrist across the country, this was the first osteotomy you were trained with. Here's what you do. You cut the bone at a 60-degree angle, you move it over, you put a screw or a pin in it, everything's going to be great. But the truth is Dr. McAleer will show you with pictures and show you with rotational images, not just on some of his models, but on x-rays, you'll see that maybe that's not the best thing for it. The second picture, there's the Vogler, that's at 40 degrees. Okay? You can see how somebody said, well, let's just change it a little bit, we'll give it a different name, and we'll say it has benefits A, B, and C, and it has this added benefit over here above this one. It's not really the truth. Next. More examples, the Z osteotomy. You can see it's cut, looks kind of like a Z. Somebody came along and said, well, let's make it an inverted Z. Let's put the bottom cut first, move it down the side, and then go up with it. The picture on the right, I apologize, it's a little small. You can see how other people said, well, let's cut the bone here, and let's cut it there. Let's see what happens. Next. But here's the problem. Regardless of how many different ways you came up with to cut and rotate a three-dimensional object, they weren't reproducible with good, consistent results until now. We can cut and we can move things, and clinically it'll look awesome. But radiographically, like the picture on the right, and you can see those big red lines marking out some angles, the first metatarsal, that far bone all the way on the right, and the second metatarsal, the one just to the left of it, they're too spread apart. There's a big V between those bones. That angle isn't right. And when you look at it radiographically, it's hard for me to say, I did a good job for you. Now, this is not my patient, by the way. Okay. The picture on the left is somebody who had one of those procedures. it doesn't look like their foot got any better. It doesn't look like they got the result that they wanted. It doesn't look like the nervous feeling they had before the surgery gave them the result they wanted because they cared about the outcome. Okay, next. So what's the solution? How do we make it better? Because the truth is, and this may sound a little corny, but you're either growing or you're dying, right? You're either learning and trying to get better, or you're just stagnant in what you do. And you're just happy with the same old results you got. So there's constant search to make it better for other people, because the truth is service for others is how medicine works. You come to us so that we can serve you, right? So the Lapiplasty through Treats Medical, easier recovery, near immediate to almost immediate weight bearing in a big ugly black boot, but still weight bearing, okay? Return to your desired shoe gear. You can get back to sports and exercise, and the key factor is it's reproducible and consistent. Reproducible and consistent. When you engage in something that has consistent positive outcomes, that is getting better at medicine and helping people. When you look at the x-ray on the previous slide, I'm not sure that we were helping people the way we needed to. Next. I'm going to let Dr. Mackler finish up. If you have questions, please don't hesitate to write them down, okay? I'll remind you of one thing before I go. There's some paper in the back that we would like you to just fill out. We'll collect them at the end. You could just leave them on your table. It's okay. Dr. Mackler is going to show you some great, awesome pictures. You're going to leave here with an amazing understanding of how to make this problem go away, and understand that your solution is with the Lapiplasty procedure. Okay? Thank you for your time. I appreciate it.
All right, so I'll try not to bore everybody with too much information. No, not that Dr. Duke did a fantastic job. I actually want my bunion fixed now by Dr. Duke because of this lecture he gave. So my name is Jody Mackler. I'm a podiatrist, foot and ankle surgeon. I've been here with Jefferson City Medical Group for about 10 years now. Dr. Duke and I were classmates together, and he actually called me up one day and he said, "Hey, do you want to come to Missouri and practice out here?" And I told him, I said, "I don't think they let New Yorkers come into Missouri. They stop us at the border and turn us away." But actually, I've been here. My family's here. My daughters are here. And we're very happy to be part of the community and to provide you guys whatever help and service that we can. Slide, please. So currently, Jefferson City Medical Group, the Division of Podiatry, is the only center in the state of Missouri that's currently providing the Lapiplasty procedure. So this is something that Dr. Duke and I studied, we researched, we brought into the group so that we could share with the state. Now this is not something we invented. This is something that Dr. Paul Dayton has been doing. He's been working on this for many, many years. This is a big passion of his. And this is being done all over the United States. But we're happy to be the first center in the entire state to offer this to you. So again, just to kind of touch on some of the things that Dr. Duke also was discussing. We're looking at a triplane correction here, okay? So the old way that we would fix these things is we would just kind of shift them over and try to close the gap between the first and second metatarsal bones. So what we're doing now is we're not only closing that gap, but we're derotating the metatarsal. And the other thing that we're doing is we're not changing your normal anatomy. We're not cutting the bone and putting a big bend in it and making it look like a banana on x-ray. We're actually fixing the problem at its fulcrum at the point in which the deformity started. Slide, please. So this just kind of gives you an idea. This is somebody intraoperatively who has a bunion. And what we look at is we look at this altered sesamoid position. The sesamoid bones are no longer in correct position. The metatarsal bone has shifted outward. The big toe is leaning towards the second digit or over towards the pinky toe side. And you get this bump on the side of the foot over here. And this is uncomfortable. This hurts. Okay, this is where all the problem is. There's a big nerve that runs right over that bump. And that's why you're having that pain. And if you were looking down the foot, from the toes straight down, this is a normal metatarsal, normal sesamoid position. And this is altered. This is rotated. And this is what the majority of patients have. And this is why we get this appearance on x-ray. And we're going to show you what normal looks like and what abnormal is. Next, please. So this is normal. And what you can see is this is an alignment right there. That's what you want. This is a moderate bunion. And you start to see those sesamoid bones rotating. And then we have more rotation. Again, that peaking sesamoid sticking in the middle. And you can see the altered position here. So we need to correct that. We can't just cut this bone and shift it over because it doesn't address the rotational deformity of the first metatarsal. And this is why so many patients develop reoccurrence after they've had their bunion fixed via traditional methods. Next. So we want to fix our triplane correction. We want to use precision cuts that are reproducible, and we want stable fixation. And that's what this system allows us to do. We achieve all three of these goals, and we maximize the benefit, and we reduce significantly the risk of reoccurrence. This is the instrumentation. These instruments over here are what we use to reposition the bone. And this is our set of temporary fixation and our set of permanent fixation, along with our screwdrivers and everything else that we use to place our well, yeah, I know screwdrivers, everyone gets scared when they hear that. But that's what we use. It's nuts and bolts of the operation. So we have two different plating options. And I'm going to show you this a little bit more. These are biplanar plates. This is what makes this system special, because we use two small petite plates with 8 small petite screws in opposing directions, which allow for immediate weight bearing in a protected fashion. This is huge, because the old traditional methods, we wouldn't let you bear any weight on your foot for 6 weeks. Crutches, wheelchair, walker, knee scooter. Don't touch the floor with that foot under any circumstances, okay? Then on top of that, the follow-up would be an additional 4 to 6 weeks walking in a cast boot, one of those black moon boots that everyone so loves, okay? So you're looking at an overall recovery time and inconvenience of 10 to 12 weeks minimum. With these plating techniques, okay, we can get you walking the day of in a boot for 6 weeks, followed by return to tennis shoes on the day of week 6. With limited activity, can't let you pole vault and climb trees, and you know, if you're a lineman, you can't get your spikes on and go climbing up a pole, but you can maneuver yourself and get around and start getting back to activities of daily living. Again. This is just another close-up of the instrumentation that we use, and we have it on the side table over here for you guys to take a look at if you're at all interested in picking up, holding it in your hand. Just don't steal it, because they're going to charge me for it. So, next one. And there's just another, this is how it comes, peel packed. Okay, this is all disposable, brand new every time. Okay, thanks. So this is how we do this. First, we want to identify the deformity. That's step 1. And so this is our bunion, right here. There's a splaying between the first and second metatarsals, bump on the side, big toe is shifting out of position. This is what it looks like on x-ray, okay? So you can see the metatarsal is shifted, toe is drifting, sesamoids are out of position. Now we want to manually reduce the deformity. These are my fingers, sorry. You don't want to put your fingers in the x-ray beam if you can avoid it. My hands glow in the dark. So what we do is we put a joystick pin in the metatarsal. We release the soft tissue at the joint. We derotate, and we manually push this over. Just swipe up for me on that. Thank you. And we just manually reduce this in preparation for our fixation. Next slide. We want to maintain the reduction. So we get it where we want it. We want to hold it there. So how do we do it? First, we put this fulcrum in, which allows for a pivot point at the area where you're having your problem, and that stays in there temporarily during the procedure, and that's what you're seeing here on x-ray. And then what we're going to use is this instrument here, which if you take a look at the next slide, that's what it looks like, right here, almost like a C-clamp. okay? Specialized with a saddle that fits to the metatarsal and allows for us to decrease the angle between the first and second metatarsal, decreasing that angle and reducing the deformity, taking that bump down off the side without actually having to physically change your anatomy. We're not shaving bones, cutting bones, shifting bones, putting all these screws into the bone just to hold things over, and then this joint here, which is moving too much to begin with, starts to drift out over time and we get a recurrence. Nope, see you now. Next. We want to identify the joint level. So we're going to put this device called the joint seeker in preparation to cut the base of the bone so that we can maintain our position. We're just going to take the cartilage down off those joint surfaces in preparation for fusion of that joint. Next. So what you can see here is this is an intraoperative photo. There's your joint seeker. There's your positioner. There's a pin that maintains it in position. And this is real-time x-ray showing the correction. You can see the metatarsal bones have been brought back into position. The sesamoid bones are back in position. The big toe joint is back in position, and there's no bump on the side of the foot anymore. Next. Now we're going to apply our cutting jig in preparation for our bone cuts. And this is what that looks like. This sits on top of the joint seeker. So we have a slot here and a slot here. Same over here, okay? And we're going to cut the joint surfaces and we're going to remove the cartilage. We take a wafer of bone out, okay? Next. And this is us preparing, this is our saw blade. And we're going to cut there, there, and there. Next. And this is what we're talking about. Millimeters. Millimeters of bone being removed from the joint space. So we don't end up with a lot of shortening, we don't end up with problems with weight-bearing, calluses, distribution of pressure at the front of the foot in odd places. Next. And then we're going to put our temporary fixation into position. So we use a pin, it has a little olive, we call this an olive wire, and it holds the bone in position here. Sometimes we use two crossing. And then right here, we're getting ready to put our plate on. That's our first plate. Next. And we're going to put our permanent fixation in, and that's what this looks like. So you have a plate on top and a plate on the side. That's this construct here. Plantar python plate and a flat plate on top. And then we also have two flat plates as an option as well. This is great for the majority of patients right here. This is great if we have patients that are a little bit heavier, that we are worried about them distracting the osteotomy site. Next. So again, this is what they look like radiographically. This is our plantar python plate. So one plate wraps around the bottom and helps to provide support. And on this side, we have the two plates, and we call that the Control 360 biplanar fixation plating system. Names are not important, but just to give you an idea. And then what are you dealing with after surgery, right? So everyone says, well, what can I do, what can I do? Well, you're gonna have a dressing on your foot for 5 days, and then you're gonna come on in and visit me. I'm gonna take your dressings off, or Dr. Duke. He's gonna take a look, or I'm gonna take a look, and we're gonna say, you're looking good, you're doing everything you're supposed to be doing. In some cases, we're going to reapply that dressing for an additional 7 days, depending upon how well your skin and soft tissue is healing. Some patients can go without. Then we're going to have you in a cast boot, one of those black moon boots, for 6 weeks with protected weight bearing. We're going to give you range of motion exercises to do for your big toe joint to loosen it up so it doesn't get stiff on you as you go through the healing process. At 6 weeks, you can return to activities of daily living in your tennis shoes or your sneakers, depending on what part of the country you're from. We call them different things. And then you're going to return to sports and exercise and walking and spending time with your grandchildren and running. 3 to 5 months, typically, is the period of time in which you're going to get back to that. These are just some before and afters, just to kind of give you guys just another glimpse into some of the procedures that we've been doing. So again, here you can see on the right hand, my right hand side, your left hand side, the metatarsals are splayed away from each other. There's the sesamoid peaking, the joint is narrowed, and the toes drifted. And now you can see sesamoids are back in position, joint is realigned, and hardware is maintained with realignment of the first ray, or the metatarsal. Same thing. You can see here the deviation of the first and second metatarsals, and you can see them back in alignment now with realignment of the joint. And again, same thing. Large intermetatarsal angle, deviated sesamoids, big bump on the side that's really painful for this patient, deviated joint, and now we're realigned. And again, mind you, we're not cutting the bone. We're not changing the integrity of the bone. We're fusing the joint. You keep and maintain your normal anatomy. Some of these patients also had other procedures. So this patient had a hammer toe deformity, and they had a plantar plate repair, something called a Weil osteotomy. That's another lecture. We'll let you know when that one's going to come if you want to come see that one. So again, deviated, larger angle, and then smaller angle. And again, large bunion reduced with hardware. And again, this patient, oh, that's okay, you get the idea. Yeah, you messed it up. Brooke is going to take a dock in her pay now. She's going to be working for sandwiches, which we have plenty of. There you go. Okay, all right. So our website, our Facebook page, our Twitter account, if you guys ever want to reach out, contact us, feel free to contact us directly. We have an email link on our website as well. You can email us, ask us questions. We're always happy to contact you back and answer those questions. Yeah, so thank you for your attention. Appreciate it. One other thing, I just want to say, we do have a special guest in the audience. So a patient of mine who is very, very gracious to come on and visit with us. Judy's here. Judy has a very unique perspective as far as this procedure goes because she had a traditional Lapidus bunionectomy, which took her 12 weeks to recover, where she could not walk on it for 12 weeks, and then she had to be in a boot for she couldn't walk on it for 6 weeks, had to be in a boot for additional 4 to 6 weeks, and she didn't like that. So when we did the Lapiplasty, she was kind of upset with me. She said, well, why did you offer me this one before? But she had the Lapiplasty done on the opposite foot as well. So she's had one of both. Judy's here, so please feel free to speak with her. And I don't know if Judy wants to say anything, but she has a very nice perspective on the procedure and kind of what the recovery looks like. So.
Well, I'll just say that I'm so happy to have had both of them done. And to tell you the truth, after the first one, I was a little hesitant whether I wanted the second one done or not after what all I'd been through being on that scooter. But when I found out about the new procedure, I was like, let's do this. And just almost day and night difference. With the first one, I was on the scooter for 6 weeks and then in a boot and an additional 4 to 6 weeks. And very limited in my activities. On the second time, I got to walk in the booth the next day, and that was huge for me. If you've ever ridden around one of those scooters, you can understand. So anyway, if you have any questions, I'd be happy to answer any. Can I tell a funny story about Dr. McElroy?
Oh, please. I like to be embarrassed. I like funny stories. Please do.
I had the second one on June 22nd. So, anyway, after a while, it was in the heat of the summer, and that boot was kind of hot. So I went in one day, and I said, when I had my appointment, I said, do you happen to have a cooler boot? And he told me, well, you can bling it if you want to. I said, no, I can't.
Thank you, Judy.
I didn't bling it. No, we discussed that and thought maybe it would add some weight to it, and I didn't want that.
Well, you would have been the first person to bedazzle one of those boots.
Bedazzle, that's what he called it. Bedazzle. You could bedazzle it.
And I have a bedazzle at home, so I will come and I will help you bedazzle it. So, but really, thanks everyone. I really appreciate the great turnout. Hopefully we gave you some education here, like Dr. Doof said. And if you guys have any questions, we're open to answer them.
Do we have Q&A right now?
Yeah, please, please go right ahead.
Great, I've got about 4 Q's here.
Sweet.
So, do you do this outpatient here at JCMG?
This is done outpatient at JCMG. Currently, we also do, depending on insurance, some of the patients are being done at St. Mary's Hospital, but it's the minority of the patients. Majority, I would say 90 to 95% of all the cases are done here at JCMG.
And that's basically an insurance issue?
That's an insurance issue, yes, but we're trying to work on that as well.
What about nerve damage? I guess all surgery has risks. Is there a risk of nerve damage to your foot or your toe?
The approach that we're using in the location of the incisions, no matter what you do, anytime you make incisions, there's small microscopic nerve fibers that get cut. We can't help that. But the major nerve branches, we know where they are, and we work around them. So the incisions are not in line with those nerve branches, so typically we don't see them. And if for some reason you had a different anatomy, where your nerve branch crossed in a funny position, we would just move it out of the way and retract it. Sometimes patients will say, well, my incision feels a little numb here, but that comes back typically with time if you just wait it out over the course of your recovery. The main complaint that we get with any surgical process, because everything we do is in the limb and swelling kind of collects down into the leg, swelling will compress the nerves, and sometimes you can get a sense of some tingling or shooting discomfort at times, or some numbness. And those typically are not permanent and they go away. It's a function of the swelling. So when your swelling goes away, that nerve irritation goes away too.
And then, I don't do any sports anymore, but I like to go to Healthplex and walk on the track and do strength training. So it really would be like 3 months of not being able to do that, is that right?
3 months of no high impact activities, but you can get back to some very easy walking. I always tell patients, we're not out there, we're not power walking, we're not doing the Greenway, we're not doing laps at the mall. We're just taking like a leisurely stroll for maybe a 30-minute grocery store trip or something like that. I'm always very conservative with how I treat the patients because I don't want them to get into any trouble. But usually by week 12, what I'll tell you is a gradual return to activity in a practical way that you're physically comfortable with. So I don't know if you feel different about that, Dr. Duke.
Well, I'll tell you, Dr. Mackler and I both like to be active and like to exercise. So if there's an exercise you want to do other than running, we're going to be able to help you develop a modification to do some of those things that you want to do. Because one of the primary complaints that we get with any lower extremity surgery is they come in a week later and they go, my calf muscle's gone. Where'd it go? And people start slapping their calf, right? Well, we can help you and talk through some exercise activities that you can do during that period before you can return to those higher impact activities. Okay, so that there's always a process where we can modify some things and help you maintain that cardiovascular, that cardiovascular strength that you've built up over time.
And then, how long does it actually take you to do it? Like an hour, 2 hours?
Right now, I was making a joke about this the other day. Look, and don't get this wrong. We're never in a rush. The surgery takes as long as it takes. But I keep telling everyone, I can't crack 51 minutes on this thing. There's just so many little extra steps and additional x-rays and double checks. And what we're looking to do is we're looking to get you the most perfect result that we can offer you with what constraints of your anatomy we have to work with. So far I haven't gone beyond. I haven't been at my old procedure when we used to do a Lapidus. I could do a Lapidus in 40 minutes. So now I'm like, I've added 11 minutes to my procedure. But again, patients have better outcomes, and it's worth the extra time and the effort. So.
Yeah, I don't want you to rush.
No, no rushing. No, that's fine.
No rushing involved.
There's no rush.
52 minutes.
Yeah, sorry, 52 minutes, 60, whatever it takes.
Go ahead. Oh, sorry.
So how long have you been doing this procedure in Jefferson?
so in Jeff City, it's been introduced new this year. Okay, so I believe first procedure was performed, actually was it March, April, around
March,
there.
April region.
Okay, so but what I want everyone to understand is, even though it's a new procedure, it's a build out on a traditional procedure that Dr. Duke and myself have been doing for over a decade each. So the Lapidus, which is the traditional fusion procedure that we used to do, which was all very much eyeballed. I would go in and I would cut the joint and I'd look at it and I'd move it and I go, oh, I kind of like that, I don't like that. I do my best at reducing the bunion intraoperatively, and then I would fuse the joint. That's something we've always done. So the difference here is some of the instrumentation allows for better correction, and then the fixation is slightly different how we put it in. It's not that plates or screws or anything is not what we typically would do. So it's all something we've always done, but with a little tweak and refinement, if that makes sense.
Dr. Mackler hit it on the head. It takes the eyeball out of it, right? It takes that, well, am I good? Am I right? Am I almost right? And puts it to where you know it's right. So it takes that guesswork out of it, if you would. Yeah. Go ahead.
So how many have you done?
This year so far, 20, right? 20 about. How many have you done, Duke? I don't know. Maybe we're probably combined with pipe correction, like
Yeah,
30, maybe 35.
35.
Yeah.
Maybe a little higher than that since March or April.
Do you ever do both at the same time? Both of you at the same time? Or the other?
That in my book, yeah, it's a big no-no.
I tell people no, and I'll give you the reason why, and it's fine. I want you to have one foot that you're very, very comfortable walking and pushing off on. I want you to have one foot that when you step up, you know that that's not going to hurt if you have some steps to get up into your hole. I want you to have one foot that you feel comfortable that if you need to stand and take a little rest because your other foot's a little tired, you can do it. Okay. Plus the incidence of potential complications goes up when you do both at the same time.
Yeah, I agree. Makes me nervous to do both feet. I want you to have a good foot to stand on. So if this bothers you, you can lean, or if you were to stumble or trip, you have a foot you can kind of come down and touch down with. Yeah.
Good question. Yes, ma'am.
Am I understanding that there is hardware that you leave in place permanently?
Yes, ma'am. And that's typical of any bunion procedure. Yeah. There's always plates, screws, so on.
What's the metal made out of?
Titanium. Titanium. So it's very non-reactive, so we use it for all different types of orthopedic surgery in general. It's the same metal that we use for when we fix an ankle fracture, for fusing a different type of joint, for fixing fractures. And it's what you find in knee joints and ankle joints and so on and so forth, the replacements.
Sure.
I have titanium in my back and I never set off any alarms.
That's a ringing endorsement right
I
there.
don't even know it's there, and
Yeah.
it's just been a blessing to have that stuff back.
Excellent.
And Dr. Mackler touched on it. They are very, very thin plates. So there's plenty of soft tissue in the foot to cover those plates. And I have not felt them subcutaneously or under the skin for any patient that's had this procedure. Who else?
So no matter how bad your bunion is, or how kind of a bad bunion, there's still the 6 weeks in the boot no matter what.
Correct. Because what you're looking to do is you're looking to obtain a fusion of the metatarsal cuneiform joint, that joint that we're putting the plates and screws at. So that has a particular time that it takes to make that happen. So you could have a mild bunion or a very severe bunion. The joint is a joint. To reposition it, to fuse it, that's how long it takes.
What do you mean by it's reproducible?
Meaning that the results are reproducible. So what one person may do for one of those myriad of other procedures I showed you, one person may look at it and go, yeah, this looks pretty good. Another person may look at it and go, oh, well, I think this looks pretty good. But reproducible meaning that each and every time you can get that entire bone shifted back to where you need it. And I want to add this little tidbit about it. If you've already had bunion surgery and it hasn't gone well, you can still have this procedure. this procedure can help fix that picture I showed you in the beginning where it didn't go so well. This is still a definite possibility and availability for you.
And reproducible also, it's standardized. So the way that we approach it, the way that we reduce the bunion, the way that we cut the bone, the way that it's fixated, it's always the same. It's always the same. So we're always going to get the best result possible with the technique.
So once you get your bunion fixed, does it have any side effect or residual effects on like your knees or hips? Because I'm here from balances and I mean my knees have been stirred multiple times. I'm like, well that no. I mean, because your feet are in balance.
Once you build a better foundation, it just helps you. Now, it takes some time to get used to walking with that bone back in its normal alignment. And I'll have a number of people who say, it feels a little weird walking now. And my common response is, this is how it would normally function. Dr. Mackler touched on a great point. We leave your normal anatomy alone. The incisional approach and the surgical approach does not violate your big toe joint capsule itself. So that range of motion of your big toe joint doesn't get affected or scarred down. It actually improves because you're improving the rotation and the overall alignment. So you're right, as you improve your foundation, can I show you a study that your knees are going to feel better? Probably not, but I can tell you that based on angles and geometry, it does help. Yeah.
So you're actually in the booth the next day?
You're in the booth the day of.
Day up, so you can actually go back to work the next day?
No. Well, we let. Okay. No, okay. So that depends. Okay. So if you do a labor-based job, okay, you cannot return to work immediately. You have to either go on modified duty, or you have to wait out the full recovery. Okay. But for individuals who have office-based jobs, typically patients are going back within about 2 weeks, because. By 2 weeks. However, that is dependent upon the patient. Sure. So some patients will go back at 5 to 7 days because they feel good, they want to go back, they don't want to be in the house. Some patients, however, they just don't feel sure of themselves yet, and they want a little extra time just to kind of get through the initial healing process, and then they'll go back and they just kind of prop up their foot while they're working, and they do just fine. But if you're a construction worker and you're lifting, carrying, pushing, pulling, climbing, this is not going to hold up under those pressures. So that's a problem. So for our patients that are doing those types of things, you know, you do have to take some time.
But for that office job, you think 5 to 7 is probably minimum days out?
5 to 7 is minimum, because what I do, and Dr. G's protocol may be a little bit different. I typically operate on the Thursday, and then you come in on Tuesday. So I tell you, go home, relax, put it up, get some Netflix movies, you know, read a good book, just relax. When I see you on Tuesday, we can talk, and if you want to go back, even that day, I'll send you back if you want. So it really is dependent upon you. But I encourage everyone, all of my patients, to come in. I say 2 weeks, tell your job 2 weeks, because if you go back at 2 weeks, they'll say, well, you told us 2 weeks, and if you go back before 2 weeks, they say, oh, wow, you're really great. You really wanted to get back to work. So.
What about driving? Excuse me. Because it's my right foot. So
you can't drive until you can walk. So the boot is an obstruction, and
sure.
if you do we have any law enforcement here? No. Okay.
No.
So, but
on Facebook.
but if you get pulled over, it's considered a driving obstruction. So
sure.
it's a ticketable offense in many cases. So you don't want to drive, and also it's dangerous to drive with the boot on, because you can't feel the pedals, and it could lead to an accident.
And the boot is on for how long?
The boot is on for the first 6 weeks.
6 weeks.
But it's removable, which is nice also. You can take it off when you're at rest. You can take it off to do your range of motion exercises. You can take it off to take a shower, you know. You can't take it off to drive. And if you have a clutch, if you have a stick shift, and you do your left foot, that counts, guys. So you can't use it, all right? So
many have tried. I always ask, what kind of transition do you have?
Yeah.
Go ahead. Who's next? In the back?
So you operate on Thursday?
Yep.
Yes, ma'am.
Monday. Monday. I operate on Mondays.
I think you a couple years ago, which I
Good you waited.
Can we just come to you and
Yeah.
and just see whether it really needs to be done now?
Absolutely. Absolutely, 100% yes. Her question was, can you just come in and have an evaluation and get it looked at and see if it's right for you and if the timing is right for you? Absolutely, 100%, yes. Anytime you want. Yes, ma'am.
I have hammer toes as a result of my bunion, okay? Do you fix those at the same time?
Yes.
How do you fix the hammer toes?
It depends upon the patient and it depends upon the severity of the hammer toe. So in some cases, if it's at the joint towards the tip of the toe, the smaller joint, then we may just cut the bone and reduce the deformity. Sometimes if it's a little bit closer in the proximal joint, the first knuckle, then we'll fuse that joint in many cases in order to keep it straight, because the hammer toes too are progressive over time. Sometimes it's a function that some of the soft tissue, one of the ligaments in the bottom of the foot has torn, and sometimes that needs to be repaired. So it's tricky to give you a one-stop shop answer for hammer toes, because it really does depend upon what the problem is. X-rays and clinical examination can kind of break that down for us, and then we can figure out a good plan for you.
And the recovery, would it be longer
No.
because of that?
No, because the rate limiting step is the bunion. That's the longer recovery. So you're looking at, you know, weeks instead of months with the toes. So if you have your toes done, it's actually a very good opportune time to do it all at the same time. So.
You can do it all at the same time.
Yes, ma'am. Yep. In the back? Go ahead.
Okay, so I do home daycare,
Sure.
and my power
Bless you.
line is on
Yeah.
the left, and it's actually driving home daycare. Anyway, and I don't stick shit. But if I did it, would I be able to go back, even with the boot on with the kids, after, say, either a week, if it's on Monday, I got a whole weekend, or the other way around? I will put it like this, May 22nd, I had a full knee replacement on the right knee, I went back to work a week later. As a supervisor on the couch with people who work for me, so it's not like I can't have people come in and help me.
Right.
But, I mean, how would that impact with me, because I have littles?
I think the best way to look at that is each person is different. Each situation is different. Dr. Macker mentioned the laborer. You know, some people have an office job. Some people work on a computer all day. You know, each person is different, and that's where it comes in, and we start talking to you on a little bit deeper level and say, okay, tell me, give me your day. Tell me exactly what you're doing. How many people can help you with this? How many people can help you with that? And we figure out what's best for you, okay? And I'm not gonna say that there's never a compromise to any of these situations. There are, but we will discuss it with you, and we'll tell you if there's a higher risk associated with what you want to do versus what we think you should do. But I can tell you that we both operated on nurses who are walking the floors over at the hospital. We both operated on people who have very high intensity labor jobs and people who sit at a desk all day. And because each person is different, there's kind of a person attached to that foot, you know? We'll go through it with you and spend the time you need to figure out what's best.
I operate on my wife. She still talks to me, so that's good.
I really said like the showers, because I know with my knee, I had to like basically sponge bathe it until the whole scab was gone, and then I could actually shower. Is it the same when you do the foot surgery too? Do you have to wait for that whole, you know what I mean, that beginning healing process? Because I think it was probably, sadly, 2 weeks before I could actually stand in a real life shower again with my knee.
We have a thing called the shower guard. We have a thing called the shower guard that allows you to slide it over your bandage. You can stand in the shower the next day if you want. Okay.
Speaking of, how big an incision is it typically, and do you do it or do you stitch it?
Techniques vary based upon the patient's skin and soft tissue. Currently, the way that I close them is I run a stitch underneath the skin. So it's under the skin, and then there's no ties across the skin. So I clip two ends when you come in, so we don't have like 5, 6, sorry Judy. We don't have like 5, 6, 7, 8, 9, 10 stitches to remove. I don't know how Dr. Duke is currently closing. Can the skin be glued? Yes, but you want a little bit more of a secure closure in the foot just because there's so much motion that occurs, and we really want you to work on those joints, and we want you to get that big toe joint moving. So, yeah.
So we're gonna
because the codes are the same codes that we always use. Because it's not, it's a new take on an old procedure. That's it. So
Is this the procedure you would do anytime now instead of the old bunion?
the only time that the only time that you would indicate the older bunion procedures is if the patient just had a widening with no rotation and everything else was perfect and you just needed to move the bone over. There's an indication just to do what's called like an Austin bunionectomy or something where you cut the metatarsal and move it. But I can tell you that 99% of my patients are in this category and this is what they're getting.
So why are you guys the only one in the state of Missouri doing it?
Ah,
I mean, you know, we all,
Yes.
I mean, St. Louis, Kansas City are go-tos.
I brought it, and Dr. Duke brought it to the state because it was not yet available. So through our own grassroots effort, contacting the company, getting in touch with Trace Medical, getting in touch with the higher-ups there, finding a local rep that would carry the product independently. Our rep, David Lovelady, he's excellent with this product, and one of our guys over at Trace Medical, Josh Register, I mean, they've been fantastic in making sure that we had access to the technology and equipment. I will tell you that I was just at the St. Louis Podiatric Medical Association meeting, and it broke my heart to see David Lovelady there with his Trace Medical Lapiplasty booth, and I gotta tell you, there were lines. The whole place, they had a huge complex in this big ballroom with all these vendors there, and there was a line waiting for the Lapiplasty booth because people are so intrigued by it. So docs out of St. Louis, Kansas City, Springfield, all over the state now are looking to do it. So, yeah.
What are the chances if, all right, because like with me, it's on my left foot, but I don't have that problem with the right. I mean, what are the chances that at 55 eventually I'm going to have, I mean, you know what I mean? Like
Yeah.
sometimes can it just only happen to one foot and never happens to the other? Or?
It can. But to show my age a little bit, that's like the $64,000 question, right?
Yeah.
Okay. I wish I could tell you for certain, but we just can't because our foot structure does change over time.
Can you tell by looking at it if it's maybe like on the start? Or
Sure, absolutely.
if it's like,
Absolutely. Yeah. That's where the evaluation is really, really key. Yep. Go ahead.
What about bunions? Is this procedure?
That's a good question. Bunion Taylor's bunion surgery.
I would say that this traditionally would not be used for bunionette. The bunionettes don't have the same biomechanical problems that the big toe does. So in some cases the bone is just proud, so it can be shaved. In some cases the bone is bowed or angulated, and then we do an osteotomy, we shift it, and then we'll fixate it so that it doesn't move. Most patients don't require the same level of reduction at the fifth metatarsal bone that I've encountered in my practice that they do with the big toe. So, you know, could you adapt it? Maybe we should start working on that. But yeah, it wouldn't. This system particularly would not be appropriate for that.
A bunionette is just it's on the opposite side of the foot.
Yeah,
Yeah, it's by the little toe.
Yeah,
By the little
so
toe.
we call them so maybe you've heard the term Taylor's bunion. They're also called Taylor's bunions, like a tailor who sews clothing. So,
Who's next?
anybody?
Anybody? Sure.
How long has this procedure been done, like, in the US or wherever it started? Who started it and how long has it been?
So, Dr. Paul Dayton out of Iowa was the doc who came up with this concept. And so the original concept, so we do external fixation. If you ever see anyone with one of these big black halos on with pins going in and out of the bones in every which direction, if they've had major trauma, these types of external fixators are used in multiple planes in order to correct deformities and hold things in position. So he took the idea and he said, well, what if we put internal fixation using a similar concept and align the fixation in multiple planes in order to give more stability and strength to our fusion sites? Would we then be able to have something that's walkable instead of something that's not? So he's been working on this for 10 plus years, this concept. And so after literally over 1,000 patients that he's taking care of, they have taken his concept and they have adapted the technology to the current system. And that's what you're looking at. So the approach, the instrumentation, it's essentially his foresight to try to make this process easier and to give us the reproducible scenario that we want to be able to give all the patients that have bunion deformities. So.
And typically, the bunion doesn't come back, then you don't.
There's always a small chance of recurrence, but I can tell you that if you realign at all three planes and you fuse that joint, the chance of some type of reoccurrence is minimized significantly. Whereas with the old procedures, or the older, the more traditional procedures, I would say, your recurrence rate, depending upon the procedure, depending upon the patient and the level of deformity, it could be in some cases up to like 70%, even higher.
And age isn't a factor in this surgery?
It only is a factor if the patient has osteoporosis or some type of severe bone disease, where the bone in general just does not want to heal.
What about osteopenia?
Osteopenia is a risk factor that many of our patients have, and typically it's not a problem. And smoking in general, for all surgery, smoking does slow down the healing process for any type of bone or soft tissue surgery. So that is also a factor also that can kind of inhibit your recovery, just as an FYI.
I don't know if you know the answer to this question, because I know, like, since my knee replacement was in May, I know like when I have dental, I have to take antibiotics, like 4 or 5 of them before the procedure, then right after. So say, for example, I had this done in May, and I decide to do this, like, within the next, 2 or 3 months. Is it a similar protocol when you're going to have surgery again? Like, I'd have to contact my orthopedic for my knee and say, hey, I'm having foot surgery, now I've got to get around to antibiotics.
We'll take care of all that. We take care of all that, from infection control standards to working with you if there's something else going on that involves your health, whether it's you talking to your primary doctor, maybe your endocrinologist if you have diabetes, maybe your rheumatologist if something else is going on, and we will help you manage any and all of that without a problem. It's pretty common that we use a multidisciplinary approach to give you the best possible solution.
And in general, all patients that are having any type of orthopedic surgery, and this is considered orthopedic surgery, are going to get prophylactic antibiotics at the time of surgery. So typically patients are getting dosed right before they go back to the operating room to decrease their post-operative risks. Yeah, so that's standard.
Yeah, see, I wasn't sure, because I know it's like, after I had it, and I was still kind of like medicated leaving the hospital, but I had to get the antibiotics for my other thing, and he was like, not, you didn't have anything, and you got to call this, and then I'm like, okay, so like, this makes it massively complicated if I have all these other things going on. I'm gonna antibiotics, like, I might as well just carry an IV for every, you know what I mean?
I guess since you're able to get into the use quickly, that minimizes your chances of having blood clots.
This is an excellent point. So patients that don't walk have an increased risk of developing something called a DVT, or deep vein thrombosis, which some of you may have heard of from traveling in cars or traveling on airplanes. It's a big risk. So why a DVT is dangerous, it's not so much the clot in the leg that's dangerous, but if a piece of that clot breaks off, it can travel into your lung and cause something called a pulmonary embolus, which can be in some cases fatal. They're very, very dangerous. So these come on if you don't walk. So if you're stagnant and your blood pools, you're at an increased risk. So by walking immediately post-op, you're working the muscle, the blood is pumping, it's not staying stagnant, and it's flowing, and so the risk for that DVT is going to decrease significantly. I tend to still give my patients aspirin after surgery to kind of help to anticoagulate them. I know Dr. Duke uses aspirin, Eliquis, some other anticoagulation drugs. So yeah, but we try to take that always into consideration.
Is it really painful?
Oh, I was just going to bring that up. We actually provide you, prior to you leaving the operating room while you're still asleep, and this is a procedure that you do go to sleep for, an injection to anesthetize the foot for a good period of time. There's also an additional supplement that we can give you that can keep that foot pain-free for even a most common amount of pain or duration of the pain is the first 3 to 5 days. And we'll give you plenty of medicine to take care of that. Now let me kind of preface that a little bit. If you do what you're supposed to, the most common duration of pain is like 3 to 5 days. The number of times I've had to write a second prescription for pain pills for any post-operative patient when they're doing the right thing, in 11 years of being here, I can count on one hand. Okay? Most often, we don't have to do that, but we will provide you a lot of times a block intraoperatively that'll help keep you pain-free until we can start getting some medicine through an oral approach.
So that medicine that Dr. Duke is referencing, it's called Exparel. So you may not have ever heard of it, but so the traditional medication we use in many cases is a medicine called Marcaine. Marcaine wears off in about 6 to 8 hours. But Marcaine is very cheap too. It's very cheap. It's like $1 for a big giant bottle. You know, it's not very expensive at all. But we use Exparel, and Exparel lasts for 3 days. So we inject you and you're numb for 3 days, typically. 2.5, 3 days. Exparel also costs several $100s for a smaller volume, but we offer it to the patients at no additional cost. We, at the Surgery Center, absorb that cost because our primary goal is for you guys to have a good experience, to post-operatively not have significant pain, not have to take a lot of pain medication, have to deal with the side effects and the nausea and the dizziness and so on and so forth. And also, by the time that medication is wearing off, you can start taking a little bit of pain medication if you need it. Most of the patients are just taking anti-inflammatories because they don't need the big narcotic dose. And they're just having a much, much nicer experience. Because, like Dr. Duke said, the first couple of days is usually the hardest. So if we can get you through that and you can just coast through, that's great. And the big problem we have is we need to tell the patients, you feel good, you are not good. Go home and rest. Like, don't move your couch. Don't rearrange your closets. You know, don't help your friend move this weekend because you're feeling okay. So it's a very nice supplement to the procedure.
So you talked about this being a problem in the joint. So I guess in the joint it actually spreads, and that's why you have to cut and rotate because it's loose. You can't just push it back and get it in place because things are stretched and there's too much material there.
What happened? Yeah, it's absolutely correct. As the bones spread, they just don't move in one plane. They actually spread and they'll start to roll. So that big C-clamp type positioner that Dr. Macko showed you a picture of, when we attach that and we apply it, actually think about a log rolling down a hill or up a hill. It takes that metatarsal that's rotated this way and stretched out sideways and rolls it right back into place. So the old way was, let's clamp it. That looks pretty good. Look at the x-ray. Yeah, I do good work. All right, nice. And then you put it in there, but you may not have fully addressed the rotation. We can push as hard as we want and slide things, but it may not be the best to do it that way. Yeah, good question.
It's at the metatarsal cuneiform joint. Yes, so that is correct. And we have a model over there, so if you want to take a look, I can show you afterwards. Happy to do that. But that gets the slide up.
I loved your pictures. I did, they were awesome.
Oh, really? You need to autograph it for the next presentation.
So that's your joint right there that we're focusing on. We appreciate all you guys coming out.
Thank you very much. Thank you. Take a cookie.